Hi, this is Dr. Jonathan D. Hall coming to you again from Boston with another in the Thoughtful Patient's Guide to Plastic Surgery. Today I'd like to talk about the common problem we see in the office, the split earlobe. I'm guessing as long as there have been ear piercings, there have been problems with splits or slits of the earlobe. So a slit is a partial split of the earlobe that doesn't go all the way through the end, but still makes it difficult to wear earrings because the earrings pull through or don't hang well in your ear. So what causes a split earlobe? I think there are four main causes of the split earlobe. The one that springs to mind for most people is trauma, and patients will come in and say they've caught their earring on their sweater, taking it off, or on their phone, or even had a young child that pulled on their earring while they were nursing. But over the years, in hundreds of patients, I've seen this actually is not the most common cause. Heavy earrings are thought by some to be the cause, but how does that explain a patient that has a split on only one ear and not on both ears? Now, there was a doctor report recently that in his study that heavy earrings caused a stretching of the earlobes but not splitting of the earlobes, but still this could be a cause. Another reported cause is allergy to metals in the earrings. In a study reported in the Journal of Plastic and Reconstructive Surgery in December of 2004, prolonged contact of certain metals in patients with a sensitivity can lead to symptoms of allergy such as itching, oozing, redness, and gradual splitting along the earlobe. It may also be a cause for recurrent splitting in patients who continue to wear the same earring after repair. This is typically thought to be with nickel, but also can be found in other types of jewelry that are gold, silver, titanium because it can be added to the metal to make the metal harder. Nickel allergy is reported to be more common in women and can also run in families. So patients with this report that they have a moist discharge around the earring or redness and itching and a gradual splitting of the earlobe. Fourth cause, which I think is actually relatively common, is sleeping with the earrings in. I'm always trying to understand why a patient that comes to me with a split earlobe got that to happen so that we can try to prevent it from happening again. And when patients came in with split or a slit on only one side, then we wouldn't think that would be from heavy earrings or from allergies because that would have happened on both sides. A few years ago, I saw two women in my office within the same week for recurrent splitting of their earlobes. One patient had a split of her left earlobe, had it fixed elsewhere, only to have it split again. The other patient had the very same story, but with her right earlobe. So again, it's good to fix a problem, but even better to prevent it from happening again. So my aha moment came when I asked each one which side she typically slept on. And the woman with the split on the left side told me she slept on the left side with her earrings in. The one with the split on the right side slept on her right side with her earrings in. Aha. So we know that as plastic surgeons that aging involves volume loss, and we tend to have more volume loss on one side of the face or the other, and some people think it might be from sleeping in one position on a pillow. But my theory with the earrings is that friction of the pillow against the earring pushes that earring post back and forth against the earlobe and causes little micro tears that eventually lead to a split or a slit in the earring. The process of repairing a split earlobe is relatively simple on the surface, but has important nuances to get the best result. The split will not heal by itself because it's lined with skin. I jokingly ask my patients if they know the definition of a minor procedure. Do you know? Well, the answer is when it's on somebody else. So when it's on us, when we're having a procedure, we want to make it as easy as possible. So even though this is a minor procedure, I do everything I can to make it a pleasant experience. We put on some relaxing music in the office. We cleanse the ear with a special antiseptic to decrease the risk of infection. A headband can be put on to keep your hair out of the way. After marking the repair with a surgical marking pen, I then place local anesthetic to the earlobe with a very small needle. Patients often remark that this shot doesn't hurt as much as shots they've had elsewhere because I take the extra step of buffering the local anesthetic by mixing in some sodium bicarbonate before we use it. Once the earlobe is completely numb, we start with the surgery. I prepare the earlobe again with a second antiseptic, then I precisely trim the edges of the cleft. Any minor bleeding is controlled with a special Carter device. Then under surgical loop magnification, I repair the earlobe in 5 layers. A layer of dissolvable sutures inside the ear, 2 layers of dissolvable sutures behind the ear, and 2 layers of dissolvable sutures in front of the ear. This may seem like a lot of tiny sutures, but there is a purpose. When an incision is repaired, the healing process doesn't make it strong right away. In fact, incisions don't start to get stronger for 3 weeks. And they slowly increase to 70% of what their final strength is going to be by about 6 weeks. So the trick is keeping the earlobe strong enough that the edges don't pull apart and gap during the early healing phase, which can leave a notch and ruin the smooth contour that we've created on the edge of the earlobe. So a Band-Aid and some ointments placed on the ear at the end of the procedure. I have my patients remove the Band-Aid the next day and shower with gentle soap and very gently clean the sutures and then apply bland ointments such as Aquaphor or Vaseline. Patients sometimes ask why not bacitracin ointment, and the studies actually show in large numbers of patients that bacitracin has no benefit with either preventing infection or with speeding healing over bland ointments like Aquaphor or Vaseline, and it does increase the risk of allergic reaction. And now we're finding at least 10% of people have an allergy to bacitracin, which can even start to look like an infection. Another important step is that I have my patients now protect their earlobe with a Band-Aid while sleeping for the first 6 weeks. This again is to prevent that earlobe from rubbing against the pillow until the repair is strong enough to prevent the edges from pulling apart and gaping, which could either leave a little notch or a thickening of the scar. And it's interesting that the same ear that had trouble with splitting from sleeping against it also has more pressure against it during the healing period, so we want to take extra care to protect that. By 3 months, the earlobe is typically strong enough to be re-pierced again in the office. So what about the slit earlobe? Where a slit earlobe is a partial split, right? It's not split all the way through the earlobe, but it still makes it difficult to wear earrings or the earrings fall out. So it's really treated in exactly the same way. And I actually cut out that slit and then go all the way through the edge of the ear. If you just try to cut out the slit without going through the edge of the earlobe with that small wedge taken out there, then the edge of the earlobe can bulge as we bring that slit together without removing that extra tissue and give us a bad contour. Well, anyway, this has been Dr. Jonathan Hall bringing you another Thoughtful Patient's Guide to Plastic Surgery. I hope you enjoyed my talk today on the split earlobe, and thanks for watching.